Welcome to the Physician AD webinar. I'm Jay Whitehead, welcoming you to our webinar. We did title it Physician Practice AD, which stands for After Disease, which is life after BC or before coronavirus. Now we're here to look beyond the virus curve to see what the physician practice business looks like after disease or AD. I'm Jay Whitehead, again, CEO of MyDrCares, which raises and runs online patient compassion funds, the new must-have for physician practices to help doctors help patients. And we have the country's two top experts on the physician practice business to tell us what's next. Now, right now, to help doctors help patients, we're running a MyDrCares GoFundMe donation campaign that will match individual physician practice compassion funds starting next month. So your $50 donation at GoFundMe/MyDrCares will get a special gift of a MyDrCares Good For You Organics Citrus and Aloe Hand Sanitizer. Rick, this is special for you. A $21 value for free. Donate $50 today and help doctors help patients and get Hollywood's favorite hand sanitizer for free. So now, let's meet two of the country's top experts, the crystal ball guys who know what's coming next in the physician practice AD world. So let's meet them. At the bottom of your screen, Dr. Rick Sayegh. Dr. Rick came out of SUNY Albany Medical School, has been an associate professor at NYU School of Medicine, board certified in internal medicine, and even earned an MBA from the University of Tennessee. So Dr. Rick ran a very large general practice in Westchester County, New York, which sold to CityMD, and is an expert on the economics of practices. Now, he's been CEO and chief medical officer for several large healthcare practices and facilities, and is actually now available for assignment. So welcome, Dr. Rick.
Thank you for having me.
Suren Pai on the other end of the screen. If you listen to HD radio or Sirius XM radio, I've been told I have a face for radio, you can thank Suren Pai for bringing digital radio to life when he helped launch these new ventures at Lucent Technologies. And after innovating in the radio space, Suren built and led other private and public companies in wireless analytics and health IT. He received coveted degrees from IIT in India and an MBA from Dartmouth College. Now, Suren's here today because he owned a large urgent care practice and now leads and advises practices on innovative technologies and approaches to drive revenue growth by delivering a better patient experience and growing market share. So welcome, Suren. Welcome, Rick. Now let's get into it.
Thank you, Jay. Great to be here.
The four big topics that practices will face AD. Let's cover costs first, guys. So in the immediate aftermath of COVID-19, the New York Times on its front page Tuesday said that lots of practices and patient costs will go up, including out-of-pocket bills for patients. So in your opinion, what are the biggest areas of cost increase? Rick, why don't we start with you?
Sure. I think the biggest cost is going to be the what is necessary to make up for all this COVID. What we don't know about, the complications, what's to come in the future, all the downstream costs that we have. The immediate costs are the costs of overwhelming our healthcare system. Not only do you have all these COVID patients coming in, you have all the regular patients coming in as well. And then we're missing a lot of those things and they're not getting the care that they need. All the maintenance care, the preventative care, things like that is being neglected is going to go up exponentially when we try to make up for what's going on here with the COVID. As far as the COVID costs themselves to the patient themselves, you're going to find that there's going to be a lot of things that aren't covered from different disease states that they will have on top because of COVID, from shortness of breath, chronic respiratory disease, heart disease, so from all the remnants of COVID.
Suren, from a business practice perspective, do you see those same costs popping?
Well, I think it's not so much the costs, Jay. As Rick mentioned, from a patient perspective, there's a risk here in terms of what the payers will cover, what they will consider related to COVID, unrelated to COVID. So there's clearly a risk. I think you're entering uncharted territory here. And So from the patient perspective, that's the risk. We'll just have to see how things sort of pan out. On the practice side, I think you have a whole host of issues other than cost. I think the real issue is going to be how they're going to be able to collect on their receivables, past receivables, future receivables, just because of the economic impact. As things get hard for patients to pay their bills, that is clearly going to show up in the cash flow for these practices.
So the out-of-pocket bills are clearly an area that's going to
Absolutely
jump.
Absolutely, and that's going to be a result of not because of the disease itself, but just the economic aftermath of everything that we're facing.
Now, one of the biggest costs for most of these practices is staffing, right? Staffing and training. What changes there in terms of on the cost side and for staffing and training? It looks like there's this virus has had a huge impact on the human resources of practices. Rick, what do you see? What do you see there on the staffing side?
Well, a lot of the practices are struggling now because they went to telemedicine. So their income is a lot less. Their volume is up, but their per patient income is a lot less. So they cannot support as much staff. So they're going to have to start letting some staff go, as well as they won't be able to do the things they were able to do before because they're so overwhelmed. So if you're normally seeing 30 patients a day, now you're going to have to see 50, 60 patients a day in order to make up for the forget about the lost revenue, just to keep up with the patient demand. So staff is going to be overwhelmed. You're going to see staff and doctors, unfortunately, starting to cut corners just to get through to what they have. And I really hope that the patients don't suffer as a result. Just like a hamburger chain, if you overflow it and trying to get the hamburgers in and out, the quality is going to go down. And unfortunately, we're in a business where you can't sacrifice quality. You make one mistake, people die. That's one. Two, from a staffing perspective, we're human just like everybody else. We're going to get sick. We're going to be tired. We're going to be fatigued. And at the end of the day, we need to recover, but we don't have the opportunity to do that. We're working nonstop now, and we're going to have to work even harder after this is over just to try to clean up the mess and catch up and get the state of health, the foundational health of people back to normal.
Suren, does the recruiting pitch for a physician practice materially change after this? Is it going to be harder for them to get people?
I think a lot of the existing challenges will continue, Jay, which is it was already hard enough to recruit providers and staff and to deal with the sort of the ongoing employee churn in the business, the attrition, the natural attrition of much higher than most other sort of industries. But Rick makes a good point. Yes, it's going to be harder for these practices to operate just because of some of the squeeze that they're going to see on the margins. But I think there's another aspect to this, which is because of this shutdown, I think not just the providers, but employees are also facing for the first time and questioning, or will be questioning, if this is their right career choice. And that hopefully that's not going to be a huge factor, but there will be some impact. And what that will do is make it more difficult, obviously, from a supply demand standpoint in terms of staff. It could make things more difficult. And some of them who believe it's still their right career choice, but don't want to be with their existing employer, may cause a higher rate of churn. And what that means is, again, staffing and investing in training and all of those things, which again go towards reducing your margins.
So two more, just keeping on that cost theme, two more questions there. First of all, let's start with you. Go back to you, Suren, on technology. You're the technology guy here, the designated geek in the group, I guess. Practice is going to have to spend more on technology. If so, what technologies?
So practices have spent a lot of money in the last 5-10 years on EMRs and adjusting their workflows and their work practices around the EMRs. But I think one of the interesting things that's happened, Jay, let me just step back for a little bit to provide the context for why I'm saying what I'm saying. I think if you look at what's happened with this coronavirus thing, I think none of the secular trends that have been underlying the change in the industry is necessarily going to change. So you have all the issues around, consumerization of healthcare, the consolidation of practices, the quality of healthcare, the cost of delivery, all of those issues, and risk-based compensation, all of those things will still continue. That's not going to change. However, those forces have forced practices to focus on the one differentiator that they have in their control, which has been patient experience. That's the only thing practices have to be able to maintain their patient base, grow their patient base in what is essentially a market share environment. And I'm talking about independent practices, primary care practices, specialty groups and others who rely on primary care for referrals. But bottom line here is it's a market share game when you're playing against large consolidated players who have vast resources, are highly integrated across a lot of specialties, across inpatient, outpatient, long-term care, and all of those things. And when you're fighting against a highly consolidated payer group, so these practices, the only thing for them to fight against, the only lever they have is patient experience. And that lever is being squeezed. And why is it being squeezed? Because in this environment, as patients are going through this coronavirus experience, two things have happened. Some of the patients who have wanted to see their doctor, for some reason other than coronavirus, cannot see them because many of these practices are shut down. So that is affecting the patient-physician relationship. Second thing, some of these patients don't want to visit doctors' offices because they're afraid that they may be exposed to coronavirus. For these reasons, I think there is some level of distancing of that patient-physician relationship, which coming out of this entire crisis, the practices will have to approach very aggressively and find ways of rebuilding all of these relationships. So patient experience is going to become even more critical in this new environment. But secondly, your question around technology. So during this entire phase, as Rick mentioned, many of these practices have gone to telemedicine. But patients have also been forced to experience telemedicine in a way that by choice they may not have. And I think that experience is going to wake patients up to the question of, hey, if we can do this conveniently from my home at a lower cost, because a lot of the payers are promoting telemedicine, then why do I need to go into the doctor's offices? And that puts a further squeeze on the margins, as we discussed. But coming back again to the question of telemedicine, the experience that patients are having, the experience that payers are going to gain through this and saying, hey, a certain subset of services can be delivered via telemedicine is going to make telemedicine one of those things that's going to become very critical as a new channel of delivery. And it won't happen across the board. Obviously, visits that require physical presence cannot be substituted by telemedicine. But lots of other things like prescription refills, like follow-ups to follow-up types of visits. Behavioral health is another big thing. And I think what you're going to see is the payers starting to steer patients towards these channels. It's already happened, but it's going to accelerate the whole process. Therefore, practices that do not employ or deploy these new channels are going to be left behind in the dust. That's just my sort of view in terms of what's going to happen coming out of this.
You paint a bleak picture, Suren. So Rick.
No, I don't.
Is technology the friend or the enemy of the practice, Rick? And if so, what's friend and what's enemy?
Well, I agree with a lot of what Suren said. He's absolutely right. It's a friend in a lot of ways. There's a lot of things that we usually didn't get paid for. For instance, refilling prescriptions that now we can do via telemedicine, review of labs now that we can do with telemedicine. Unfortunately, I believe, just to go back to the patient-doctor relationship and the patient experience, that has been the backbone for doctors, especially primary care doctors, internal medicine, family practice type physicians, forever. Unfortunately, now since EMR, doctors are focused on the computer and focused on writing, doing paperwork and being secretaries, and not really being doctors and looking at patients. We're staring at the computer screens. We don't even greet the patients like we used to. So the doctor-patient relationship has been fractured for a long time, for lack of a better word. So now I think that this is just going to perpetuate it. And to go to telemedicine, you lose, there are certain things, like I said, that are telemedicine friendly, that are a lot easier for the doctor and for the patient. I don't want you to sit up and take a spot up just because you need a prescription. But at the same time, I don't want to just refill your prescription without examining you. If you're on blood pressure medicine, you might not need it anymore. So I can't do certain things. Take your blood pressure for one, listen to your heart, listen to your lungs, do a urine sample, things like that to check for protein, and not to get too technical, but there's a lot of things that I can't do. And those are important to your health. So I think the only person that's going to suffer more than financially for the doctors are the patients. Although there are a lot of things that, if you're on a maintenance medication for a long time, you're not getting off, that's one thing. But when you come in, you might be here for a refill, but I might find 3 or 4 other things wrong with you, and I can address those during the visit, where I can't do that in a telemedicine type environment. One, because a lack of exam. I can't listen to your heart, listen to your lungs, things like that. So technology is a friend, definitely. But I think, like Suren said, in certain instances, not for every instance. I think there's nothing that's going to replace the in-person visit. He mentioned behavioral health. I think for psychiatry and all behavioral health, I think that's there shouldn't be an alternative, unless you're going to pay out of pocket, for payers and for the patient and for the doctor. You can do it from the comfort of your own home. To you're basically in front of them, whether you're on the couch or you're sitting on the computer, you're getting the same experience. And prescription wise and things like that, if they need to send you out for testing, they can do that. So I think it's definitely a friend, but in the right instance.
Just for those of you on the webinar who just joined us, I'm Jay Whitehead, CEO of MyDrCares. That at the top of the screen is Suren Pai, economics expert for practices, and Dr. Rick Sayegh, longtime practitioner and an expert on the economics of practices. So let's go to that last question about on the cost side about Medicare. So Medicare, I hear, Rick, and I may have heard it from you, and then read up about it, that Medicare spends 35% of its budgets on claims avoidance. And claims avoidance is a big part of the equation. And the private insurance companies do something similar. So tell us, does that claims avoidance practice continue or accelerate after the virus?
I think no question it's going to accelerate. One, the government doesn't have the funds, nor do they have the reserve to pay for all these claims, all these extra claims. We have all these extra claims from COVID and non-COVID. Now every time somebody doesn't feel good, they're going right to the doctor or right to the hospital, thinking they have COVID. As you might have heard on the news, 6 out of 10 people don't have COVID right now with the same symptoms: the cough, the fever, shortness of breath, things like that. So that being said, there's an overwhelming amount of claims going through now, especially with telemedicine. Just like we said, it's more convenient for the patient, maybe more convenient for the doctor. Doctors are staying home, and now they're home all day, not really going to the hospital unless they have to, and now they're able to do telemedical visits. So the normal day, before COVID, where you do maybe 10, 15 telemedicine visits and then see the rest in person, now you're doing almost 100% of it telemedically. So the overwhelming amount of claims, I don't think Medicare, one, is going to be able to keep up with the cost. Two, I believe that they are going to try to recoup some of these costs after it's all said and done. They'll go back and do audits, things like that. And instead of them saying, okay, we'll pay us back $100,000, they'll offset what they owe you. Let's say you bill them $200,000 in telemedicine, they'll give you the 100 instead of the 200, and saying that we overpaid you 100 or whatever the case may be. And I don't think that's just for Medicare. I believe that's going to happen all over. United Healthcare, Blue Cross Blue Shield, all the private payers. So I think there's no other way that they'll be able to, meet this demand.
So, Suren, let's use that Medicare theme as a way to transition into talking more directly about telemedicine. You've recently had some experience transitioning practices into telemedicine. So, tell us about the reimbursement rates. Are you seeing those go up? Are they down? What's your experience?
So, Jay, before I jump into the mechanics of the whole telemedicine thing, I think the one thing I want to point out is you had mentioned my background in sort of creating a paradigm shift in the radio industry. This was about 20 years ago when we took the radio, AM, FM radio industry from analog to digital and what's now today as HD radio, and also the emergence of XM and satellite. I used to tell my radio broadcast clients at that time that, listen, there's something called wireless data that's coming. And they didn't understand what I was talking about. And I kept talking about it for 5 or 6 years. This was in the late 90s, early 2000s. And of course, 3G, we're talking about 5G now, but 3G was going to emerge in 2006. The rest is history. We know what happened. 3G came out in 2006. Then 4G came out. Then you had services. Then the iPod, the iPhone got released in 2007. iTunes came out, Pandora came out, and so now where does the radio industry stand, right? My point is, new technologies like telemedicine are going to force the healthcare industry, at least some segments and some services, force them to innovate. And there is no avoiding innovation in terms of how you deliver services, what types of services you can deliver, what kinds of technologies, not just telemedicine, but lots of other things. and I'll reel off a few things. There are technologies available for, I talked about patient experience. There are technologies available right now to try and, improve the patient experience in terms of online experience that the patients have before they step into your practice. Things like chatbots. AI is coming on board in terms of interacting, answering patient questions, all things related to things like, hey, what types of insurances do you accept? Where can I go this? Do you offer this service, that service, etc.? That's just one range of technologies in AI. A second set of things happen to do with internet marketing, not just Google SEO, SEM, but things like look-back marketing and other things that are sort of showing up on the horizon. We've implemented all these technologies for our clients, right? But going back to your question around telemedicine, so very recently with one of my clients, fairly large practice, we turned around and implemented a telemedicine service in roughly about 72 hours from start to finish. My client said, hey, patient volume has dropped 50 to 70% in terms of in-person visits. Business is going to go down. We got to do something. We turned around, implemented a telemedicine channel for this client, roughly in about 72 hours. First day, we saw 50, 60 telemedicine visits. Second day, it went up to 120, 130. 150, the new target is about 250 visits a day, right? Now, talking about telemedicine costs, telemedicine has been around, but nobody was forced into using it. Payers have been paying for telemedicine visits. And again, telemedicine falls into two categories. One is audio only, which means you pick up the phone, you have a chat with the patient. The reimbursement rates, firstly, Medicare doesn't reimburse for audio only calls. I don't believe it does. I don't think it does.
Is that
but
right?
Is
that right?
Well, it didn't, but now it does going forward because of this COVID. But I don't think that's going to last. But prior to that, he's absolutely right, didn't.
Right. So, and again, I'm talking about, excuse me, that's not a COVID cough, by the way. Anyway, no, it's allergies. I've had it for 3 weeks. Otherwise, I would be dead by now. Anyway, my point is Medicare doesn't reimburse, but most payers have been reimbursing somewhere between $10 to $15 a call for a 5 to 10 minute call, all the way up to $30 to $50 a call for something that lasts 20 to 30 minutes. But the real reimbursement is in a video conference, a video call, not an audio only call. And the reimbursement rates there. Now, Medicare has always reimbursed for video calls. That's not a new thing. That's not a COVID thing. And that's going to continue. So the ranges for a video call, all video calls are treated, and everyone on this audience understands a level 3 code, like a 99203 or a 213. All video calls are reimbursed at a 203 or a 213 rate, which means they range from roughly $75 to $140 for a new patient, or $55 to $95 for an established patient, right? Those are slightly lower rates than what you might have in an in-person visit. But at the same time, your overheads are much lower. You don't need a lot of space. You don't need real estate. So if you grow your practice and you see your practice growing, you don't have to make those additional investments in physical infrastructure. And therefore, the incremental margins may actually be pretty good, right? So what does it take to implement one of these things? Obviously, like I mentioned, we did it in 3 days, but we were not sleeping 3 nights, right, to make this thing happen. So telemedicine is not simply about signing up for a telemedicine provider. And there's a whole host of third-party services, including Zoom and Doxy and UpDocs and a whole bunch of others out there. It's not just that. It's about using telemedicine as a channel for delivery and understanding how your practice workflows need to change and adapt to use that channel, right? And that's why it's not simply a matter of a practice going out there and signing up for a service, but actually looking inwards and saying, okay, how do we actually change? What do we need to change to support this workflow? And the only thing the practices are the providers, the telemed providers are offering you is the connectivity. But all the systems that go around supporting those workflows and managing all those new workflows efficiently, firstly architecting, but then managing those workflows and training your employees to actually use those workflows, efficiently. There's a lot of work involved there. And that is custom work in terms of each practice trying to figure out how it should work for them based on the capabilities of their EMR, because now you have to actually integrate this new channel to work with your existing practice and your existing EMR.
Well, and
so let me just
before we get now, we're going to go back to Rick and talk about the telemedicine and interaction with EMR and data retention. But before that, I just want to remind you that you're listening to the the physician practice after the coronavirus webinar here, sponsored by MyDrCares, and that's Dr. Rick Sayegh and Suren Pai, our physician economics expert. So Rick, when you implement one of these telemedicine operations, tell us about the data retention. Who owns the data? What are the responsibilities of the physician practice around that data?
Well, the physician is responsible for all the data. He has to be able to produce it for both the patient and for the auditor, if it's Medicare auditing or United Healthcare. So he's responsible for it. As far as who owns it, I believe most of these are cloud-based and they're HIPAA compliant and things like that. So, unfortunately, there's a risk for breach, like with anything else, your financial information and things like that. There's that same risk here, but you hope that with these servers like Doxy and all these other servers that they're secure and protected. But I think, in my opinion, the doctor is still on the hook. Suren, if you can correct me if I'm wrong.
No, absolutely, Rick. I think at the end of the day, the practice is responsible for maintaining, managing all the privacy aspects, security, HIPAA compliance, and all of those things that come along with any patient interaction. But they have to look at how they address those aspects. But one of the nice things about some of the service providers, it cannot be delivered on something like a WhatsApp or a FaceTime. Okay, that's just, you're going to be violating every regulation in the book if you think you're going to pick up your iPhone and start a FaceTime chat with your patient. That's just not going to work. But some of the specialized service providers have made sure that their systems are compliant, not just with HIPAA, but the HITECH Act and a whole bunch of other regulations, European regulations, US regulations, etc. So using one of those apps or one of those services, I should say, which are all web-based services, is pretty safe. Now, having said that, some of these services also offer you the ability to either record the conversations, in which case, again, you're dealing with HIPAA compliant and services that are compliant with a lot of the regulations. So I don't think the liability of any kind of breach rests on the physician or the practice. It rests on those service providers because they've made those claims. But if you don't record those conversations, basically all you have is an audit trail of which a patient number you called, or how you contacted the patient, and to what extent did the video call last. What was the start time and the end time, and that really does not create any additional risk of data breaches and burdens on the practice. So I think people are pretty safe provided they go with one of these services that essentially are covered under all the regulations.
So let's go back to you, Rick, on patient retention and attraction. So with patient visits down because of the virus, they'll probably pop back up. Yes.
Yes.
They will pop back up, but people will be migrating to telemedicine because they've now seen the movie and it's not so scary. They can get some results from it, and more practices will go to it. The numbers that I've seen recently is that 28% of primary care practices in the country now have a regular telemedicine access. So let's say that's a real number. Let's say that number exists. Do you think if we came back to the same time, same channel a year from now, is that number going to be double?
I think at least double. I think if you don't offer it, especially in a primary care setting, after all this, similar to what Suren was saying, that now that they're aware of it, now they've been forced to use it, some people might like it, some people might not like it. But I think if you don't have it, you're going to become obsolete, one. Two, I think from a medical legal standpoint, we have to establish with the regulatory agencies, Department of Health and things like that, what kind of visits are really appropriate and what you can do and what you can't do from a telemedical visit. There's different states have different rules. There's when the telemedicine first started, you have to have applied for a telemedicine license. There's some rules about the doctor has to own the in a telemedicine company, the doctor has to be the owner. It can't be working for a private person, things like that. There's so many different rules. Every state has their own rules. There's not one system. I think if this happens next year, same time next year, there has to be a universal recipe in order to practice telemedicine. And I think there needs to be some training and residency trainings for telemedicine. It's a new thing. It's an up and coming thing. Doctors aren't always tech savvy, one. Patients themselves aren't tech savvy. So I think that should also be part of the process. Three, we need to be more alert and more aware of what is appropriate. There has to be a delineation of what's appropriate and what's not appropriate. In this instance, we're doing it for an emergency, for a pandemic. All the rules are out the window at this point. We're trying to do it for safety and public health and not to overwhelm the system. Hopefully a year from now, that won't be the case. So I can't stand behind and say, oh, we had a pandemic, I had no choice, this, that, and the other thing. Then, it's easy to play Monday morning quarterback. When everything's going well, nobody's going to say anything. Second, there's something wrong. Why didn't you make the guy come in? Why didn't you do this? Why didn't you do that? And next thing you know, you really don't have a leg to stand on because there is no guideline.
Yep. So I got a call. I got an email last night, actually, from. And by the way, if you want to contact Suren or Rick Sayegh or me, Jay Whitehead, email CEO@MyDrCares.com. That's CEO@MyDrCares.com. If you got a question, you want to contact anybody, please email that, and we'll get you right to either Dr. Rick Sayegh or Suren Pai. So I got an email last night, guys, and the question came from a physician practice here in New Jersey that's transitioning part of its practice to concierge medicine, that subscription high-end concierge medicine, and saying, oh my God, I think that concierge medicine is dead. A lot of the people I've recruited for my concierge practice are canceling now because of this. What do you guys think about that? Is that a real trend, concierge medicine, or is it just a niche thing? Rick.
Concierge medicine's been around, I think, for a long time. I did practice some concierge medicine. It's a niche area. You have to have the clientele. You have to be in the right location. There are some large organizations like MDVIP and things like that that are specifically concierge. The models have changed. The prices have become a lot more affordable. When they first came out, I believe you needed to pay $5,000 to $10,000 just to be a member, and then pay about $250 to $500 a month just to be on the panel. And
that's country club medicine.
Say again?
Country club medicine.
Oh, absolutely. And then, that would include just for you to be on the panel, and they would bill your insurance for any ancillary things like that. And then you pay a la carte, so to speak, every time you came. Now that model works for the people that have money and the people that can afford it and wanted convenience and things like that. They did offer, at that time when it first came out, I don't think there was video. Now there is video, but it used to be on the phone. I used to give you my cell phone number. You'd call me and I'd come, either make a house call or of course for an additional fee. That's not included in the membership fee. But just to have access to me that's what you were paying for. I think a lot of these companies now are struggling, one, because a lot of people from the economic downturn from this COVID, they can't afford it to pay the membership fees and the things like that. Now they're much more affordable. I think MDVIP, they have one for I think $1,000 membership fee, and I think $50 to $75 don't quote me on those numbers, but I'm pretty sure something in that ballpark a month. It is relatively affordable, but you don't get the same service you were getting before. So now because they lowered the cost, the doctor's carrying more on his panel. It was 100 to 150. Now it's 300 to 500. You get the cell phone number, the secretary, this, that, and the other thing. But, you can only see one person at a time. So if two people are sick at the same time, before there was no waiting, you wouldn't even sit down. You'd come in, sign in, and then go right back to see the doctor. Now, because it's more affordable and the panels are larger, it doesn't work like that. So really what you're paying for is convenience and I think security. You think that you have the doctor's cell phone number, he'll call you right back. But the way I've always practiced medicine, you beat me, I'll call you back. I mean, my poor wife and children suffered because of that, but I would always be on the phone. So I was given concierge medicine without getting the premium. I don't know if that's the greatest business model, but I became a doctor to help people, not to, try to milk it. Don't get me wrong. Everybody wants to make money, but you have to, at least do what you're asked.
So Jay, what do you think about that concierge thing?
Yeah, so a couple of points I want to make. I think Rick is absolutely right. Going back to an earlier point around why telemedicine is going to become a must-have or a must-offer for physician practices, the answer, and I'll give you another nuance to this. If you look at what payers are doing today, when you log into a United Healthcare website, if you're a United member or you log into Blue Cross Blue Shield or anywhere, one of the first things they offer you is, can your needs be satisfied by a telemedicine call? And right there, the payers are disintermediating you from your physician, because if you opt for that channel, you end up using one of the generic services like Teladoc or one of these other things, where you're talking to a physician that you probably never met before or never even heard of. So if patients are going to start opting for telemedicine video calls or audio calls, and they're going to be steered away from their personal physicians or their PCPs, I think it behooves physician practices to offer that same level of convenience to their patients. Otherwise, they're going to see a segmentation where patients who don't care about talking to their personal physicians or their PCPs are going to say, hey, I can just log into my United Healthcare website and start a call with Teladoc. I don't need to talk to my PCP, right? So I think physician practices have almost no choice but to start offering that channel and create some level of customer stickiness or patient stickiness in terms of them using their preferred PCP, their PCP as a preferred physician as opposed to a Teladoc provider who they've never heard of, never met, right? So anyway, that's why I believe your number will go up from 28 to 56 or 70% or whatever be the case. But coming back to the question of concierge medicine, right? I think this proliferation and this expansion of telemedicine will actually have an effect. I don't know if I'd call it country club medicine. It'll certainly not expand country club medicine, but it'll have the effect of democratizing concierge medicine. In other words, concierge medicine will expand, but will have to segment itself into the kind where you either have limited access by video or you have extended access until 9 p.m. or 10 p.m. and then making the lives of people like Rick more miserable, but that might happen. And or if you want a personal visit from a physician, which might cost you $500, and that may not be a problem in places like Manhattan, which is pretty dense, and a practice can have hundreds of concierge or country club medicine clients and be able to visit 5 or 10 of them in a day. So I think it'll have the effect of expanding access to those types of services. It'll take some time, but I think it's coming.
So let me let you guys see. So you guys are the crystal ball guys. So I'm gonna put you on the spot here. So right now there are 230,187 physician practices. 230,187 physician practices in the country. A year from now, what's that number? Suren.
I'd say at least 20% less and declining pretty fast. And the reason I say that is because I think until this point in time, every physician practice has felt invincible to any kinds of shocks or black swan events, only because those black swan events were economically based. You had market crashes, you had the 1987, you had the 2000, you had the 2007, 2008, but it didn't affect healthcare because everyone needed healthcare and it was the demand was inelastic. This time around, I think a lot of practices for the first time have experienced what I call vulnerability. When something like this happens and it shuts down your practice is bleeding, your practice could shut down, your practice could go bankrupt and never reopen. And I think for the first time, a lot of practice owners are going to feel that fear, which says, oh my God, I'm not as invincible as I thought, because this kind of thing can destroy me. And what many of them will be looking for is saying, okay, how do I manage my risk going forward? A big part of that risk management is going to be consolidation. Some are going to say, I don't want to deal with this again. Some will never recover from this crisis, right? And that's why I say what I say, which is you're going to see a significant number going down, never reopening. Many will consider their strategic alternatives and say, I've got to join up and group together with other folks or join a hospital system. I can't take this anymore.
So Rick, Suren set the number at about 185,000 down from 230,000. Where's your number?
I completely agree with him. I'd say even a little bit lower, maybe even 40% lower. A lot of patients, practices that aren't associated with a large medical center or have any backup that are the solo practitioner. I think those days are over. At least even before all this, you had to kind of join, and the people that kind of stayed out of that now are definitely feeling it. As he said, this is the first time healthcare used to be insulated from any economic changes, whether the market was up or down. It really didn't matter on healthcare. Now, this is the first time that healthcare is really being impacted. I think at the same time, we see how valuable healthcare is, but you
Absolutely.
also see how vulnerable you are, as he said. So I completely agree with that, and that you're not invincible, and that if you don't have backup from a large hospital or somebody to take the brunt of the expenses, then you might not be able to survive it. And I think once you close, you're never going to be able to reopen again. The expenses are so overwhelming that you just cannot recover. And so I think it'll either go close your practice and go work for somebody. You know, people that had their own practices, it's safer. You got a guaranteed check. You don't care about whether, you know, reimbursement goes up or down. It's, you know, you get a fixed income. And I think in the old days, you know, being a doctor was very lucrative and things like that. Now it's just like a regular job. The only difference is that you have to put in 7-8 years of school, $300,000-$400,000 of loans, and you know, they're making it into a more of a 9 to 5. When I was doing it, you know, there was no such thing as a 9 to 5. I'm off the clock. You can't page me. Now doctors, like everybody else, want to clock in and clock out and go home. The younger doctors, you know, we used to have to work 36 on, 12 off, or any variation of that. Now you can't work more than 80 hours, which is safer for the doctor and for the patient, by the way. So I'm 100% for this. But now it's more like shift work. You know, you have hospitalists, you have you know, shift type work, where in the old days it was just the emergency room doctors that worked shifts. Everybody else was on when you're on. Your patient went in, and I don't care if it's 3 in the morning, because your patient's in at 3 in the morning, you get up and go in the hospital. Now it doesn't work like that. So I think that trend happened before COVID. And I think after COVID now, from the financial aspect of it, it's a no-brainer. I think most practices are going to either consolidate, as he said, or join one of the big players.
And one of the things here, Jay, is you know, just to add to what Rick said, I think the underlying theme is not any one technology or telemedicine or anything. I think the underlying theme is innovation will become far more rapid and will be forced down on the healthcare industry. And the pace of innovation will force a lot of the small practices who just don't have the wherewithal to either make the investments or don't have the ability to stay ahead of the curve to just fold or join up. So I think innovation is going to be a big driver here.
Well, so a final reset before we go to our final question. We've got Dr. Rick Sayegh down there at the bottom, and Suren Pai, our patient practice or our physician practice economics experts. And let me pose you the final question, guys. I'm Jay Whitehead, by the way, CEO of MyDrCares. And if you want to contact with Dr. Rick or with Suren Pai, email me at ceo@mydrcares.com and go to MyDrCares.com to donate to our Patient Compassion Fund. You'll start seeing Patient Compassion Funds launching at physician practices around the country. And if any of you want to hear about that, please do email me at ceo@mydrcares.com, ceo@mydrcares.com. Final question for you two. Let's, in that physician practice AD world, after the virus, what are your top 2 takeaways for physician practice leaders? What are the 2 big themes in this next period that are really going to, that if you don't pay attention to it, you're dead? Why don't we start with you, Suren, and then we'll go to you, Dr. Rick, for the last word.
So as I said before, Jay, I think the one and most important thing is going to be delivering a superlative patient experience inside the clinic, outside the clinic, in all aspects of interactions with patients at all touch points. And also, you know, building that bond and maintaining that moat so that you can maintain or grow your market share. And it involves not just patient experience, but also staying on top of market feedback, all your internet marketing things, and a whole host of other things, innovative techniques in terms of how to retain that patient. So that's one thing. And second is going to be all about, you know, how do you adapt in terms of the innovation that's coming? How do you adapt and adopt new technologies and new methods and new practices, new management methods, whatever may be the case, but you have to change if you want to survive. So it's going to get tougher, not easier. And so people will just have to have a growth mindset around what's coming down the pike.
So let's go to you, Dr. Rick, for the last word here. What are the 2 top takeaways for physician practices after this pandemic? What are you going to have to do? What are the 2 things you're going to have to do or die?
Well, that's a very, very good question. I think I definitely agree with what Suren had to say. Additionally, I would add to learn from our mistakes. One, be more prepared so that this, this can happen again, and it probably will happen again. We learn our lesson. You learn more from your failures than your successes. So let's learn our lesson and be prepared for the next time. When I say that, not only as physicians and physician practices and hospitals and government, things like that, but also as patients. Make sure your foundational health is good. If your baseline health is good, you can withstand this. As you see, the people that are immunocompromised and things like that are the ones that are really suffering from this virus. But it might not be called COVID next time. It might be something else. So take care of your health. And two, I think we need to repair the doctor-patient relationship, and doctors need to stand up for their patients. We've been, unfortunately, due to insurances and due to this and due to that, government and all that, we have been unable to deliver quality health care the way we want. We're not putting the patient first. We're putting the payers first, and reimbursement and documentation. We're not treating a piece of paper. We're treating patients. Pieces of paper don't cry. Pieces of paper don't die. Patients do. So we have to put them first. Try to take some of the bureaucracy. We should learn from this and try to get rid of some of the bureaucracy and the red tape that happens in medicine. Yes, I know there's a lot of details that we still have to attend to, but we're missing the most important detail, and that's the patient. And I think if we focus on the patient, and everybody's focused on the patient and the patient outcome, not only will you thrive from a humanitarian and social perspective, but you will also thrive from a financial perspective. Just do the right thing.
That's fantastic advice. So I want to encourage everyone who wants to get in touch with either Suren Pai or Dr. Rick Sayegh. Email me, CEO at MyDrCares. I'm Jay Whitehead, CEO of MyDrCares. And again, go to MyDrCares.com. I will be launching patient compassion funds for doctor practices around the country in 2020 to help cover out-of-pocket non-Medicare patient bills for those patients who are in need. And we're in the meantime, we're raising a fund that will match into those funds as well, either on GoFundMe, so our GoFundMe campaign on MyDrCares campaign on GoFundMe, or you can also donate on MyDrCares.com. And if you do a $50 donation, remember you get that the Hollywood's favorite hand sanitizer as well as a premium gift. I know Rick likes that in particular. So I want to thank you on behalf of Suren Pai, Dr. Rick Sayegh. This is Jay Whitehead with MyDrCares saying thank you very much. And don't be a stranger. Feel free to email me, CEO at MyDrCares.com. Thank you.
Thank you.
Take care. Thank you.
Thank you, Rick. Thank you, Suren.
Thanks, Jay. Bye.
Bye.